It's time to open the session on non-chemotherapy treatment modalities in hematological malignancies. Our first speaker today in this session is the eminent Professor Mohamed Azazi, and he is going to deliver a talk about non-chemotherapy treatment modalities in non-Hodgkin lymphoma. Please, sir.
شكرا. طبعا شرفني دعوه السيده الدكتوره ميرفت والجمعيه لإلقاء. نعم.
الصوت.
انا؟
عايزين ميكروفون يعني
تسكتوا تسمعوا. عموما هقفل الميكروفون وهتكلم براحتي.
تعمل اللي هي عايزاه.
يا باشا تأمر يا فندم.
سبت
كويس كده؟
ايوه كويس كده.
تمام. هخلي الموضوع سهل جدا بالنسبه لزمايلنا اللي هيبتدوا بعدي. I'm going to make things very odd and very strange. And not only that, I'm going to change every concept we have nowadays. Not only the concept, but the future and the direction of our treatment. The first question is simple. Should we go for targeted therapy and the era for chemotherapy is obsolete or not? The question is simple and the answer is complex, but yet simple. The question is, chemoimmunotherapy era is ended or is almost over. Let us be a little bit polite. Almost over, but it is already over. And the question is true. To settle this doctor problem, we're going to go for the first example, which is a CLL patient who is old, young, who is fit or unfit. The question will be answered by the following pictures or figures you're going to see. What in real life is totally different from those you see in the statistic. For example, you are going to find in every study that is being done in this world, there is what's called exclusion criteria. I will not include a patient with renal impairment, cardiac patient, but we do not have this luxury in our clinic. We treat CLL patient who is elderly, who is diabetic, who's having hepatitis C, who's having cardiac or renal problem. We do not exclude. So let us go for what is the true story. If this is the true fit patient who is CLL or an 80-year-old patient, is this true? Or the actual picture, this is nearly what we see in our life for an 80-year-old Egyptian patient. Not only that, but let us go for what's called the selection bias. Usually on the average, when you go for a real life, a patient who is 80-year-old is having at least 2 to 3 morbidities. And by far, the studies usually include patients who are younger by 10 years. So 10 years younger and no morbidity, while you are talking about a man who is 10 years older with 2 to 3 morbidity. This is the patient who is going to be enrolled and approved for a study, and those are the patients who will be rejected from the study, but we treat them. So enrolled in a trial, not enrolled in a trial. Not only that, but should we change this picture? Should we have a patient who is going to be treated for any kind of acute leukemia, chronic leukemia, myeloma? This is the classic picture you see in our life, or a patient who's going to present to your clinic. Should he look like that? No hair, vomiting, always in a state of misery, or what's called the chemotherapy face or the chemotherapy attitude. You see this patient, he's not going to be treated from flu. This is a true picture that needs to be changed and must be changed. Some of the studies have shown that non-Hodgkin lymphoma CLL patients are generally elderly and have at least one comorbidity, but the comorbidity can go from one disease to the other. In fact, at one point, chemotherapy by itself was more damaging to some patients more than the disease itself. Let us go for real life or what's going for the past 20 years. The SEER group have studied patients from since the year 1975 until 2005, and they have concluded that the majority of patients have at least 4.2 comorbid status that interfere with the patient's life and even are life-threatening to them. On even 1/3 of them will have 3.6%, and a minority will have 2.9%. So on the average, you're going to find more than 4 comorbid states in patients. This makes tailoring treatment in your clinic or in your practice a little bit difficult. A patient who is 70-year-old on the average who is having at least more than 4 comorbidity, I doubted that he's going to receive anthracycline, he's not going to receive Fludara, he's not going to receive a lot of medication. And so you can see that the more the patient gets old or the senior patient are having more and more comorbid state. By the age of 55, 2.9% will have an ischemic heart disease event or pulmonary problem from smoking, but by the age of more than 75, all of them, nearly all of them will have a comorbid state. This range from this classic example, a patient who's 62-year-old was having a cardiac comorbidity because he used to be smoking cigarette and he is diabetic, platelet count is a little bit low, and diagnosed with chronic lymphocytic leukemia, the mildest hematologic problem ever. This patient is a real-life case, not like those who are enrolled in the study. Another person who is 59-year-old is anemic, hemoglobin is low, the lymphocytic count is 30, creatinine is 66, and is having a kidney problem that needed to be treated. This, again, a real-life case, and he needs to be treated. When you go for practice, FCR, that once was, for example, the treatment of care for a patient with CLL, is not a good option in high-risk patient. You can see here that the mortality for those patients, not the IGHV unmutated cases, will differ completely, and for 17B deletion patient, those patients will not do well, and the overall survival of those who are receiving FCR did not show improvement on the long term. So the disadvantage of this is that it's poorly tolerated for elderly. Myelosuppression is a major problem. Risk of therapy-related myeloid neoplasia is high, ranging by 5% per year, which gives us a very poor prognosis in the future for those who survive this, what was once called cure favorable biologic treatment for those patients. Let us go for the NCCN guideline. Remember, this is only the version 5, 2018, only 1 year ago. You will find that they start to merge what's called the targeted therapy and as a first-line therapy, obinutuzumab, and the other line of treatment like ibrutinib, and the other line of treatment started to put their foot in the first-line category. And not only that, also for the relapsed refractory patient, either alone or in combination with bendamustine, Fludara, or rituximab, or other medication. But when you go for the last version, 2020, you will find that the story differed completely. The first line for those patients who are CLL without, remember this are without deletion 17B or TB53 mutation, you will find that the pentagram has changed completely. The preferred regimen in 2020 is ibrutinib, venetoclax again, and for those patients who have other options, will go for rituximab, obinutuzumab, or ibrutinib plus obinutuzumab, and you will see that chemotherapy-free era has starting from this year for those patients with non-Hodgkin lymphoma and for those patients with CLL. Even for those patients who are less than 65 years old of age, they still will go for ibrutinib, venetoclax with or without obinutuzumab therapy, and the outcome of those patients is improving. So we are now pushing ourselves. Only 1 year ago, we had chemotherapy. Now we have chemotherapy-free protocol. Less chemo, more targeted therapy is now going on. Let us go for those without deletion 17P, and you will find that they have the acalabrutinib, which is now category 1 approved, ibrutinib category 1 approved, rituximab, venetoclax, and the dovelisib, as well as the aldolazib and rituximab. And remember, preferred regimen in the year 2020, no chemotherapy again. And we'll see for those patients who fail to receive the treatment, or even those elderly or young patients, again, the pentagram does not change much, and the choice of treatment is still chemotherapy-free protocol. So even more or less chemo, more targeted therapy is now the standard of choice. A new post-second line chemotherapy, maintenance therapy now has been advocated for CLL patients, and this includes the ofatumumab as a category 2B, as well as lenalidomide has been now approved as a maintenance therapy for patients with CLL or small lymphocytic lymphoma. Let us go also for those patients who have the relapsed or have another problem. You can see here that the first line still include almutuzumab and ibrutinib, venetoclax, obinutuzumab, as well as for those relapsed refractory patients, still venetoclax and the new small molecule have emerged as the first line of therapy. Again, you can see here for relapsed refractory patient with deletion 17p, no chemotherapeutic agent will be used in the very near future for those patients. No chemo, but only targeted therapy. Remember, this is only 1 year ago, and for those patients with deletion 17b, the same ibrutinib venetoclax with or without the use of aclatomab is also considered. Not only that, but for the sake of the future, the special consideration for the use of those small molecule or what's called the small molecule inhibitor have made it quite important for the NCCN guideline to include those drugs in detail. For example, the dose of the drug, the lymphocytosis syndrome that will occur early in the suspected cases, and this should not hinder us from continuing the treatment and should not make us change our treatment, because at the beginning you will find some what's called lymphocytosis that is quite harmless and should continue. Infection is a problem with divarasib, which is another small molecule inhibitor that has been approved. Venetoclax has gained a lot. Adagrasib is now available in Egypt, as well as ibrutinib, which is now used in a dose of 420 milligram orally daily until disease progression. So targeted therapy for CLL is now the standard of care for those patients. The BTK, the B1-3K, and the BCL2 inhibitor, monoclonal antibody, and the SIC, as well as the CAR-T therapy that now have shown very promising results for those patients with non-Hodgkin lymphoma, as well as for patients with CLL. So again, no chemo, but targeted therapy will continue. Ibrutinib proved itself in many studies. For example, the RESONATE trial has shown that a patient, the curve immediately after the second month of treatment diverged to two different directions. With the first time, we have the luxury to talk about progression-free survival, overall survival improvement for a patient with CLL. Remember, those are senior patients who are relapsed and refractory to treatment, and the 12 months update for this study shows that there is a better progression-free survival for those patients. 24 months update, the improvement gets better and better. In fact, 78% was achieved in a reduction in the risk of progression or in the risk of death, 74% improvement. Ibrutinib also in the RESONATE study has shown that 4-year follow-up for those patients that nearly 60% of them achieved what's called good progression-free survival compared to 3% of those who received the FCR regimen. This was regardless of the baseline clinical characteristic of the molecule or the molecular feature, whether the patient is deletion 17 or 11q subgroups or this or without complex karyotype. So all patients did improve or showed an overall survival improvement after 12 months study. Nearly 60% of them did have reduction in the risk of death for those patients who are relapsed refractory to treatment or could not find a proper line of treatment. Follow-up for 25 months still showed 86% of those patients did do well with the drug compared to 64% from other line of treatment. The RESONATE study also showed what's called overall response rate, which is higher with the drug, and you can see that you can compare 78% compared to 10%, and when combined with other medication, the improvement was shown to be better, and the tolerability of combining this drug with other was better. Even we had a response rate that was higher when they are combined to other medications. So this led to the FDA approval in 2014 of ibrutinib as a first-line therapy for CLL patients who received this drug. So after 2-year update, you can find that the drug is very effective in patients who are having deletion 17, TP53 mutation, and those who have 11 mutation, and the response rate is improving by time. So from second line to first line, based on the presence of the Helios study or the Helios trial, where a combination of the PR with or without ibrutinib was tested in 578 patients. And the overall response rate was nearly 82%. And those patients did well, and the combination was quite tolerable by the majority of those patients who were before deemed as patients who are not responding to treatment. Another new player is the venetoclax that has gained a lot of popularity recently because of the myeloma study. This is used as a monotherapy or combination therapy, and this was well demonstrated by the Clarity study and the famous Murano study. Alone or in combination, venetoclax did do well on patients even with deletion 17B, either as monotherapy. It has shown an overall response rate of nearly 40%, and the FDA approved the drug in 2016 for relapsed refractory deletion 17B CLL patient in young and elderly population. Combined with ibrutinib, the response is even better and better, and this was shown in the Clarity trial, where it leads to response with 6 months improvement in the overall survival was nearly 100%, which is a figure now you can talk about that I can treat almost every patient in my schedule. Not only that, but now we have the luxury of talking about we can push our patient to what's called minimal residual disease negative based on bone marrow and other modality. Even 1/3 of those patients will achieve the relapsed refractory patient. 1/3 of them will achieve a state of minimal residual disease comparable to near cure to those patients. The Clarity was quite well, 100% overall response rate, and 1/3 of the patients tolerated the drug and did quite well. When the Murano study extended for 2 years, again, the benefit was more and more by the time, and those patients had higher and higher minimal residual disease negativity, ranging to more than 60% of our patients, and the better overall survival. So, for the first time, without chemotherapy, we're talking about a patient who can reach near cure or overall response rate quite tolerable with a medication that will not cause vomiting, will not cause serious side effect like the standard chemotherapy that we used to use before. Obinutuzumab is another first line in the elderly, and it has shown comparable result with reasonable outcome, and it doubled the progression-free survival and the overall survival of those patients, making it a very effective line of treatment. Not only that, but it has shown higher rate of minimal residual disease negativity, and even a trend toward overall survival benefit was achieved in elderly patients, leading to its approval by the FDA in 2013. Another first-line treatment is not the combination, but the use of RESONATE-TRU trial or the RESONATE-2 trial, where the overall response rate was tested for those patients when you compare ibrutinib versus the CIB, and the response was independent of the presence of high-risk feature. And you can see here that, again, the small molecule, despite being small, but they are large in their efficacy, and you can see here the diversion of the curve, and nearly 90% versus 34% of patients achieved a state of progression-free survival, and overall survival was better when they were tested for a period of 2 years. Now, ibrutinib versus chlorambucil, and this is the outcome of the RESONATE-TRU trial, and you can see that you can find here that nearly 90% of the patients did do well with ibrutinib, and many of those patients did have a state of negative minimal residual disease. Again, untreated deletion 17B, even the outcome is better. Remember, we used to talk about relapsed refractory. Now, let us talk about the true first-line therapy. The drug will be used as a first line, and this led to the approval of the drug as a first line. Illuminate phase 3 trial, ibrutinib with obinutuzumab versus the classic ibrutinib chlorambucil in untreated senior patient, and you can find again that the outcome of those patients, whether they are having an unmutated immunoglobulin gene or not, did benefit quite much from the progression-free survival, judging by the diversity in the curve, and even those patients gained more than 14 months in overall survival. That's it. So for the unfit, we did show benefit from not using a classic, which is expected, not using a chemotherapy. What about the fit patient? Again, the ECOG Akron E1912 and the captive study, where they tested ibrutinib versus FCR or venetoclax with rituximab, with or without the use of FCR, and both studies have confirmed that, again, ibrutinib in younger population who are not treated. This is a study that was published in the ASH 2018, and the subdivision was published recently 1 month ago, and it has shown that the ibrutinib rituximab arm was doing by far much better result when they compared the result. The result was more pronounced in patients who are having IgHV unmutated status compared to those who are having a mutated status, and the progression-free survival of those patients was much better. This led to the conclusion that the findings have immediate practical changing implication and establish ibrutinib-based therapy as a first line in a patient with CLL, and this is what's called the NCCN Guideline recommendation, that unprecedented improvement of progression-free survival over overall survival of those patients, leading to the use of small molecule like ibrutinib and other products for the fit as well as the unfit patient, for those who are having deletion 17 and those who are not having, based on the captive study phase 1 and 2, as well as the other studies. Remember here that we have reached with some of those medication 82% MRD negativity. If you are interested in MRD, whether in the bone marrow or in the other modality or tested by other modality, this was based on the ASH 2017 as well as 2018 recommendation. Thus, an novel therapy is more tolerable, more durable, and it achieves a deep and deepest response compared to other medication. As you can see here, the obinutuzumab response, and the majority of patients will go, 77% will have a state of response rate with a deep molecular response that is maintained for a period of more than 3 years. You can see here that also the deepest response was maintained in nearly 40% of our patients compared to 3% who went into classic line of treatment. What about the other non-Hodgkin lymphoma? Non-Hodgkin lymphoma classification has led by what was given by the scientists of the WHO in 2017 to better understanding of the molecular biology of, and subsequently better classification of non-Hodgkin lymphoma patient. The category is quite endless. In fact, when you use a small figure, you can find that better classification, better treatment, and 2 pages for the staging or sub-staging of patients who are having B as well as T and natural killer neoplasm as guided by the WHO classification 2017. 2019 guideline, version 5, showed that for those who are having follicular lymphoma, the standard of care now is again anti-CD20 that has pushed itself to be the main player for those patients, whether they are having any kind of categorization, stage less than 7 centimeter or stage 2 or 3. Again, anti-CD20 was the standard of care for those patients. For follicular lymphoma who are going to transfuse to diffuse large cell lymphoma or transformation status, those patients also received what's called a promising new drug or new modality, which is the exablagine, which a state of, or the CAR T technology for the management of those patients, as well as a new kind of treatment with the ibrutinib, another monoclonal antibody that was shown to be very promising as a first line for patients with relapsed or refractory follicular lymphoma transforming to diffuse large cell lymphoma. Another issue, for those who are having multiple lines of prior therapy, you will find here again that a monoclonal antibody is the standard of care, as well as the CAR T technology has emerged as a first line of treatment for those patients because of the success of such treatment on those patients. So for follicular lymphoma grade 1 and 2, the preferred line of treatment as FDA approved for the first time. The FDA approved what's called biosimilar. Sufficiently, the cost is now exceedingly expensive that FDA started to approve a biosimilar product, and those lists include many drugs, including lenalidomide, rituximab, and obinutuzumab. Not only the generic now are starting to work, or what's called the biosimilar. Also, for those patients who are having a follicular lymphoma, again, the use of obinutuzumab, rituximab, and other combination of monoclonal antibody is now a standard of care. But not only that, but you can see here, second line and subsequent therapy will include the small molecule adalimumab and cabiralizumab and dovelisib. Those 3 molecules are now gaining popularity, and they are considered as the second generation for the adalimumab molecule. Less chemo, more targeted therapy. What about the gastric multi-lymphoma? Again, rituximab is considered as one of the standard treatment for those patients with without antibiotic therapy. Nodal marginal zone lymphoma, you will see the anti-CD20 is also considered as the first line treatment or the initial therapy for those patients. And remember that chemotherapy is now receding in all the figures or the graphs I have shown to you. Nodal marginal zone lymphoma and ibrutinib is now the standard of care or now considered to be a drug very promising for those patients, as well as the use of PET scan modality for those patients to judge them whether they are CR or in a state of PR or not responding at all. Splenic marginal zone lymphoma is another drug, is another disease that has received rituximab as the preferred line of treatment, and the outcome of using rituximab in those patients is by far, whether they are hepatitis positive or negative, is by far better than the conventional chemotherapy. Marginal zone lymphoma, ibrutinib, lenalidomide with or without rituximab are now category 4, category 2B, and they are pushing themselves to a higher state, as well as the ibrutinib, category 2B for the treatment of those patients, as well as for those patients who are having marginal zone lymphoma. Again, biosimilar are now approved, including the small molecule lenalidomide, ibrutinib, and rituximab for their treatment. What about the mantle cell lymphoma? Again, the RDHA is now the standard of care for the induction therapy for aggressive disease, and it should include rituximab as the best care possible for those patients or the standard of care. Mantle cell lymphoma, you will see here that again the small molecule with or without lenalidomide therapy are now being introduced, whether you are going to use ibrutinib or acalabrutinib or venetoclax. Again, first line treatment depends mainly on those marvelous molecules. Bortezomib rituximab combination has been used with success on some patients with mantle cell lymphoma. For the diffuse large cell lymphoma, still the standard of care is the R-CHOP, where rituximab will play a major role in all the kind of treatment that will be used for those patients. The CAR-T technology now has emerged itself for those patients who pass into a first relapse or second relapse, and the drug and this technique has shown very promising results. So even for diffuse large cell lymphoma, lenalidomide maintenance therapy has been approved, and the line of treatment now is changing, including brentuximab vedotin as a second line treatment. Monoclonal antibodies are gaining popularity. Ibrutinib, lenalidomide, and rituximab are also included. This is a glimpse for what's called the chimeric antigen receptor or the CAR-T T cell therapy that are gaining popularity. The outcome for those patients is even better and better for those who are having non-Hodgkin lymphoma and CLL. Two line of therapy or two line of different kind of therapy has been used for follicular lymphoma, mantle cell, diffuse large cell with quite success. So CAR-T now are included, what's called the future for the cure of diffuse large cell lymphoma. Some of us will be faced with post-transplant lymphoproliferative disorder that was very challenging to be treated and quite difficult to eradicate. Again, rituximab is a drug that has shown itself to be promising, as well as the new drug, the rituximab, is now having a very, very better response rate to those patients with Castleman disease, particularly as a first line or primary line of treatment for this patient, regardless of the HIV status of those patients, positive or negative. Either the cetuximab or rituximab are now the standard of care for those patients. For the relapsed or the refractory Castleman syndrome or Castleman disease, again, bortezomib, rituximab, and the tocilizumab, or what's called the kinara, thalidomide, lenalidomide, rituximab combination are also used with quite success for those patients who were found once to be ineffective for treatment. Again, the small molecule has given the chance for the Nccn Guideline to put them as part of their category, to be remembered by all physicians that new drugs are now the standard of care for those patients. The good physician treats the disease. The great treat the patient who has the disease, but should we change our perspective of patient-doctor relationship from a vomiting patient to a patient who is treated in an outpatient clinic? And not only that, all patients can be treated without vomiting, without hair loss, without complication. And I thank you very much.
Thanks, Professor Azazi, for his comprehensive and fruitful presentation.